We're going to get started here. On the call with me today from STS, we have Leanne Jones, Emily Conrad, Catherine Holyfield, Sydney Clinton, and Melinda Offer. And then from IQVIA, we have Joe and Michelle. Melanie is not able to be with us today. This is the Adult Cardiac Surgery monthly webinar for April 6th. Just STS important dates, some updates, and then we're going to review the audit results from 2021 and then some tips and tricks and if your site is selected for 2022 audit, and then Q&A. Important dates for adult cardiac today is the monthly webinar. April 20th is the user group call. And I just provided the next couple monthly webinars and user group calls for May. To get us to the harvest close, harvest 2 closes on May 27th. That's going to include your OR dates through March 31st of 2022. Please, please, please try to get your data in as early as possible and cleaned up. Our last harvest close, there were sites doing a lot of cleanup getting their data in and doing a lot of cleanup on Friday of harvest close, the day that harvest was meant to close. And there was if you will, an IT traffic jam that occurred, and some of the sites were in panic mode trying to get their data in and cleaned up, and things kind of froze. IQVIA worked with those sites to make sure new data was accepted in past the end of the date, past harvest close. They worked with those sites on Monday of that following week. But I could tell you that stress is no fun. So if you can, and you're able to get your data in early and cleaned up, please do so you don't have to go through that. Opt out for harvest close is June 1st. Okay. That's my spiel on making sure you get your data clean and cleaned up and submitted in time. The harvest dates, I'm going to share this, I think, every monthly webinar, just so we have it on our calendar, and I'll let you know if anything changes, which nothing has. But just as a FYI for you all, as reminders for things that are coming up. The Harvest 4 data was posted March 14th. I just want to talk a little bit about this, and I'm not sure if I did on the last user group call, but the data was posted. IQVIA usually updates the data over the weekend, and then they updates the platform over the weekend, and they like to make sure that the data has all loaded correctly. And so that usually takes place kind of usually like Sunday night, Monday morning. So sometimes you'll notice the data is posted and we haven't notified sites. That's just because we're making sure that everybody's data has loaded correctly. So if you see data up there, it's not that we don't want to let you know that it's there, but we will send notification once we're certain that everything has crossed over correctly from the, there's 2 environments. One is like the kind of getting ready to post it, and then the other one is called the production environment. And we'll let you know once everything crosses over into the production environment, which is what you all see on your end. We'll let you know when we're certain that it's all good to go. And so we weren't not notifying sites. We just wanted to make sure everything was updated correctly before notifying you. April training manual is posted. Harvest 1 data, that's going to be the next star rating report in the data that we will use for public reporting, which will be refreshed at the end of summer, probably August or September. The Harvest 1 data OR dates through December 31st, 2021. That data is due back from DCRI in the next few weeks. So we should expect that data back. It takes IQVIA a couple weeks to prepare that data for publishing to the production environment. So we'll give you more information on that as we're able to, but just know that it is due back from DCRI here shortly. All right. I am going to go over our audit results for 2021, and then we'll talk about the audit for 2022. 113 sites were audited. We do audits. So first, we do audits usually every year. We did not do an audit in 2020 because of the pandemic and the strain at sites during that time. We reinstituted the audits in 2021. We looked at data part of 2019 and part of 2020, just so 2019 did not go unaudited. We included 6 months of 2019 and 6 months of 2020. We do the audit, it's more for a confirmation that our data in the national database is accurate and it maintains the integrity that the SDS database is known for. So I'm happy to report that just about everybody out of the 113 sites did it amazingly well. For the audit, we select 20 medical records. They're randomly selected. It's a mix of CABG, SAVR, or CABG plus SAVR cases. Again, the cases were performed for this audit. They were performed between July 1st, 2019 and June 30th, 2020. We audited 130 version 2.9 data elements, and the overall agreement rate was amazing at 97.6%, which just shows that there's a couple of factors to consider when we look at overall agreement rates and why we're doing so well. One, of course, is that Melinda has spent so much time on the training manual and really has worked hard on providing updates and answering questions and just being a great resource for folks when they send their questions in and getting back to you all very quickly. Her knowledge is immense when you look at all of the different variables that she must educate on. So she does a great job. You also do a great job in reaching out for questions, making sure you understand the data definitions, and also attending these webinars in AQO. Complication agreement rate was 98.4%, and the discharge mortality agreement rate was 97.7%. These audit results are up from the previous couple audits by a couple percentage points. So it's really amazing. It just shows that we're all working together, and we take our job seriously when it comes to abstracting and getting great data submitted in, working with our surgeons or the heart team to do that. This year we implemented an audit policy. We had always had a policy in place, but it had never really been formalized. So this year we formalized that audit policy. And what we did, and I'll show you on the next screen, we'll go through the audit policy, but what it does is it kind of provides a grading of meeting expectations, exceeding expectations, or not meeting expectations. So 69 of the sites exceeded expectations. Very, very good, which means consistently over 98% for the data for the fields that were audited. 34 sites met expectations, usually between 98%. We'll go through it in the next screen. And then 10 sites, except for the complications and mortality fields, those were a little bit more strict on, where 98% or higher meets expectations. But for the other fields, we look at 90% as meeting expectations. And then 10 sites did not meet expectations. And with the formalization of the audit policy, it means that those sites will need to be re-audited again in 2023. So but what's most impressive is that 31 sites got 100% on their audit. If you're one of those sites who got 100%, congratulations on doing that. It's a lot of work, ensuring that all of your data elements are abstracted accurately. We're talking about 130 data elements that you abstracted for 20 cases perfectly. So congratulations on that. And really and truly so proud to see that we had 31 sites this time. So thank you, and good job, Melinda, for everything. Thank you for everything you do. So here's the audit policy. I highlighted the sections that relate to when sites will need to be re-audited. And this really isn't a punitive thing. It's more about helping you if you have questions, or maybe there's various reasons why sites might fail, might not do greater than 90%. And 90% in school is considered an A, but for accuracy of the database, as you know, we're very proud of the integrity of the database, and we want to maintain that. So having over 90% accuracy is important for that. So it's not punitive, but, and I realize that you have to report your outcomes or your audit results to your surgeons and to your C-suite folks. And you might have to answer to them if you have a poor audit result, but for purposes of STS, it's not punitive. We're here to help you and make sure that if you have questions, we can answer those. If there's any confusion, we can help provide clarification. And sometimes it's even that perhaps we're not doing everything exactly as needed for you to do your job. So what kind of feedback can you provide us that we're able to push out to all of the sites that improve, provide you with the tools that you need to do your job. So a site achieving less than 90% accuracy on the complications or mortality section will require an audit. And I'm going to talk a little bit about that mortality section in a second. Sites identified as not meeting expectations for overall site accuracy, or sites having less than 90% accuracy on the complications or mortality section will require a follow-up audit in 2 years. And we define not meeting expectation as less than 90% for the audit. Sites identified as continuously. So if your site is audited and you have to undergo a re-audit in 2 years, it does kind of put you at risk. We're not sure how stringent this will be because this is the first year that we had a formalized policy. But the surgeons are considering, what can we do? We don't want bad data in the warehouse. And if you're just not able to meet the expectations, then is it really fair to continue accepting your data in the warehouse and combining it with the national data, which if you're a larger site could impact the outcomes, could impact the national benchmarks. So they are considering that you would be at jeopardy of not participating in the database until your site is able to demonstrate that you're above that 90% agreement rate. So with all that being said, I just wanted you to be aware of this. This is posted online underneath the STS National Database, the section for additional resources where it says audit information. The audit policy is posted there. But if you are a site that will need to be re-audited and you would like assistance, please feel free to reach out to Melinda or myself, and we're happy to provide that guidance for you. Sometimes sites might have a difficult time if there's turnover rate, if you're being pulled to different areas, this isn't your only job, or if maybe you just aren't that familiar with it and you're new to the database and kind of got thrown in. I think a lot of the folks that I have talked to who have reached out for help, it has come, and this happened to me, and Melinda has shared her story too. Her and I both kind of had a little bit of knowledge of it, but when it was time to abstract and it was our sole responsibility to abstract the database, we didn't really have a whole lot of experience with it and kind of walked into messes. So I've heard that from quite a few sites that, the data manager before them had been gone for a year, or had been gone, all of a sudden left or went to the floor or something like that. And then all of a sudden this kind of fell in their lap and they have absolutely no experience with abstracting the data. And they're trying to play catch up for months of records, months of cases, and they just don't have that experience to quickly go through and abstract cases, and it takes more time and all of the things that go along with that. So if you're in those situations and you need help or you need some ideas on how to catch up or anything like that, just please reach out to Melinda or myself, and we're happy to help you with that. We want to see you succeed. That makes us feel good, I think, right, Melinda?
Yes, I'm happy to help anybody that's struggling, because I certainly struggled the first couple of years I did it. So
Yeah, I think when I started abstracting, it took me an hour. No, it took me 8 hours to do one cabbage case. The first cabbage case I did, it took me 8 hours, and that was painful. And I think it was really painful for my boss because I kept asking her questions. I didn't know to reach out to the STS for help. And then, by the time within a year or so, I was down to like a half an hour, 40 minutes for a cabbage case, but in 2.81. But there's a learning curve. And I think we all acknowledge that, and we're here to help. So please reach out if you need it. There are some variables. I went through all of the audit results, and I'll show you my notes in a second. I went through all of the audit results, and I kind of looked at, national issues versus site-specific issues. Some sites just really had a hard time with all of the data elements, and those are the 10 sites that need to be re-audited. But there were things that happened nationally where I could see it in sites who otherwise had really good audit results, but these were the fields where it seemed like folks were struggling. So coding of primary insurance, height and weight, and there's reasons for these, and I'm going to talk more about it because I looked at the auditor's notes on these. Chronic lung disease and severity, alcohol use, blood count, all of the labs we had issues with, just about all the labs we had issues with. Heart failure is historically, heart failure NYH classification, ejection fraction, historically we've always scored lower on these. Thankfully, this audit, we did better than in the past, but we're still at a spot where I think we can help each other improve. The valve data, we always have problems with this, so we'll talk more about that. And then STS risk calculator and postoperative peak creatinine. So I looked at all of these and kind of reviewed some of the auditor's notes. I noticed, where there was trends about why things were not coded exactly right. I know this is a very busy slide. Melinda and I are going to review this in more detail, and we'll come up with an education plan about how to help, do we need clarification? Do we need to, in the training manual, do we need to educate something? Do we need to talk to sites to figure out, what's going on? Why are you having a hard time with these fields? And we want to hear from you if you are having a hard time. There are a couple other factors, and I'll talk about this, I think, on the next slide. And overall, you're going to say, oh, it's not bad, 95%, or 96% for race other. But I think I'm more concerned about these for your capture of risk at your site. So I'm not so concerned about overall the national results, but I'm concerned if you're having problems with these. And I saw, sites not coding, where I saw fallouts, it was sites not coding according to what was on the face sheet, and the auditor found something on the face sheet. Or, a few sites had significant issues with the race other field. Doesn't appear to be a widespread problem, but there was documentation that was just missed. So are we ensuring that we help you identify the source documentation for coding these fields? The same thing for secondary payer as primary payer, just pulled something different off of the face sheet than what the auditor found. So we will educate again on insurance. Height and weight were not captured closest to OR. That's what I determined from the notes, but you could see I'm 88% for weight field. That's kind of weird that weight's documented on every patient, and do we just need to push through that? This has to be the closest to the OR entry. So you can see we'll go through all of these on upcoming webinars. I think the valve data is always an area where we struggle, and oftentimes it's because there's so many different places to find this documentation about valve data, about the gradients, about the insufficiency, about stenosis, that it's really where are you pulling it from, the source documentation, and not that what was documented was found in the chart, and it just wasn't the right documentation to use for purposes of the database. So we'll go over that. STS risk score was pretty much that the surgeons documented that the risk was discussed with the patient, but they didn't specify that it was the STS risk score, which is what our definition says. So again, education. In this one, I was kind of baffled by this peak post-op creatinine. It happened across multiple sites. We have a score of just under 92%. But what I saw is that it wasn't the highest post-op creatinine. So we'll talk on that one. These last two are things that I do want to address a little bit on this call, just because it's going to help with sites who will be audited in 2022. The mortality status at 30 days after discharge and the readmission, STS requests that sites keep some type of tracking log if it's not clearly documented in the EHR. So if your site was audited and a tracking log was not provided to the auditor, they have no way to say that you have any type of process in place for tracking these patients to the 30-day mark, or if they were readmitted. So if you did not provide that tracking document, then these would be marked as a mismatch. Highly unlikely that we have, 90% of cases not having a 30-day mortality status somewhere. I'm sure that it's documented at the sites. It's just that that information wasn't provided to the auditor. So a couple ideas to help with that in the coming slides, and I'll go through that a little bit more detail. Same thing with readmission. I'm going to go back to mortality status. What I saw, though, there were no cases where 30-day mortality was coded as no inaccurately. It's just that the tracking documentation was not provided. So that's a really important point, because it's not that these patients were coded as being alive when they were actually dead. It's just that there was no tracking document provided, which is what we audit on. So, and the other thing is on the readmission, same thing is that if you have tracking document, make sure that you submit that to the audit company to make sure that they have that and you're verifying that you have some type of process in place. That's all we really care about for mortality status and readmission. If it is documented in your chart that that patient died and you mark it as alive, clearly that's a mismatch. We care about that too, but for the main purpose of the audit is we want to ensure that you have a process in place for tracking these patients. So what are our next steps? Melinda and I are going to work on monthly webinars and for education. And then of course, AQO, we'll try to focus on these items, include them in the scenarios that are presented, and we'll work with the presenters to make sure that we are going to hopefully cover all of these areas. Sites, to have someone familiar with the database to review documentation prior to sending. What I heard from quite a few sites is that they had a third party, either from maybe their medical record department or somebody offsite, pull the information that was to be sent for the audit, and the third party person didn't pull everything, or didn't pull everything to support what was in the database. So it's really important, if you do have somebody else pulling the data for you, just to ensure that they pull the right information. In addition to that, I think it's also important for STS to have the audit company, if they notice that something is not provided, if for some reason all your echo results are missing or your labs are missing, that they reach out and say, hey, we noticed that this is not here. Do you have it? And can you send it to us as soon as possible so we can audit that? But the accurate information. The other thing is to confirm that tracking documentation is provided. So like we just talked about for the 30-day status and the readmission status. And then reach out, we'll work with the audit company to reach out to sites if the complete documentation is not provided. And the other thing that was missing from this audit was a formal adjudicated results post-audit process. So we had a few sites who reached out who, they weren't, they had questions about their audit results. There was no formal process to update their audit results if there was additional documentation that had not been submitted, but the site had and wanted to provide to the audit company. So we will include that in this year's audit, in the 2022 audit, to make sure that we're adjudicating results and working with sites before the results are sent out to sites. So we will, there's things on both sides. Everybody, for this process, we all have things that we can work on. So, and that was a lesson learned, and we will work, and we've informed the audit company that this is a process that we need implemented for 2022. So speaking of audit 2022, We will audit approximately 110 sites. Currently, we have 1,009 sites in the database. We audit 10% of sites, so approximately 110 sites will be audited. Same case mix. We'll use 20 randomly selected medical records, a mix of CABG SAVR or CABG plus SAVR. We also audit OR logs to verify that the cases that were done in the OR within, I think it's a 3-month time period, were entered into the database if they belonged. And then we'll focus on cases performed January 1st through December 1st, 2021. This is the first time we will audit version 4.20 data. So I'll show you the audit elements. They will be updated on the STS website. The reason why that's important is because of the next point. What's ever in the warehouse at the time of the audit pull. So IQVIA will provide us with a list of randomly selected sites, including anybody who, so they'll provide us with a list of randomly selected sites. I was going to say, and those that will re-audit, but we're not re-auditing anybody this year. It will be 2023. But they'll provide us with the list of sites, and then they're going to pull the cases, the CABG SAVR and CABG plus SAVR cases for those sites between January 1st and December 31st, 2021. They're going to pull those sites and the data that's in the warehouse at that time. Any updates made to that data after the data is pulled will not be reflected in the audit process. So what's ever in the warehouse at the time the data is pulled is what will be used for the audit. It's super important that you need to make sure your data is clean and that you are happy with it prior to the data pull. I don't know the sites and I don't know when the data pull is going to occur. So essentially what I'm telling you is if you have any questions about your 2021 data, please go in and make sure that you're happy with it and it's good to go for an audit when we pull the data. Anything entered into the warehouse after the time of the audit of the data pull will not be applied to the audit. So it's again, just make sure you're happy with the data from that time frame for those cases. We'll notify sites in May-ish. Don't have an exact date on that yet, but it'll be sometime in May or early June. The screen is very busy and very small. This list will be provided on the website, and I'll show you where to find that. These are the data elements that we're auditing. This second column is version 4.20 data. You'll see some things like where we have, this is the race Black, race Asian, race other. We audit these because they are risk model variables. This change, as you all know, changed to a multi-select field. So instead of auditing these 3 individual fields, we're just going to audit race multi. So you'll see things like that. If anything was updated, we removed a couple fields from audit. Didn't really add anything special in. I did remove this. We did, not me, Dr. The adult task force, we did remove this peak post-operative creatinine level prior to discharge. And we'll talk more. I think that we removed this. There was a reason. I think it was just, I'm not quite sure, and I don't want to misspeak on that, but he felt that it was okay to remove. But we will educate on it. So this is the audit list. It will be posted online, and just make sure that you're happy with your data as soon as possible for that 2021 timeframe prior to the data pull for audit. And then sites will be notified in May, June, around that timeframe. Okay, so I guess we're going to go to questions. And I see hands raised, so I'm going to go to Annie first. Annie, if you're there, just need to unmute yourself. Hi, Annie. Okay. I'm going to go to Hannah. Hannah, you just need to unmute yourself. Are you there?
Yes, I am. I just wanted to mention the fact that we had problems with the weight because there are electronic medical records have areas that are constantly updated. So if you look on certain places, you have to find out if where you're looking for the weight, if that is stagnant and frozen in time, or it's a constantly changing variable. So for instance, we use our anesthesia and our perfusion reports because those don't get updated for the height and weight and that piece of data. So it's really important. That could be one of the reasons why there's some errors.
Oh, that's great information. And thank you for sharing that, because I think that's going to be helpful to everybody.
Well, actually, in the training manual, the anesthesia document is your source document to
Yeah.
obtain your height and weight, followed by your perfusion document. So,
Yeah, we use the perfusion because they actually check it right before actually confirm. And the anesthesia might see the patient the day before.
well, per the training manual, the anesthesia document is the priority source.
Okay.
Yeah, thank you. Thanks, Melinda. Thanks, Hannah. Okay, I'm going to go to Doris. Just need to unmute yourself, Doris. Okay, and then Jay Reese. You just need to unmute yourself. Hi.
That was an error.
Oh, well, nice to hear from you. Okay, I'm going to go to the Q&A. No worries. Thank you. Okay. I hope I'm not knocking people off. I hope everybody's still on who I just turned off. Okay, questions, Melinda. The April.
Can I make one comment about that weight, those, why we choose the anesthesia sheet as the priority? Because
Sure.
that's the height and weight that anesthesia is basing their medications off of, and their you know, their plan, their care of the patient during the OR. So we felt like that was the most that should be the priority source. So that's why that's the first one. And then if it's not on the anesthesia record, then you can go to the perfusion record.
Great. Thank you. Okay, I'm going to go to the questions now. This first one I think is going to be for you.
It is.
Melinda. Okay.
Yeah.
The April FAQ update for pre-op beta blocker states to capture patients on home beta blockers despite the lack of proof that the patient is on medication greater than 2 weeks. If the patient was admitted for a STEMI and was staying in the hospital for a cabbage and only was on the beta blocker for 10 days prior to surgery, do I still say no to pre-op beta blocker? We do have proof of the time frame, or are we getting rid of the time frame altogether?
Okay, so this is a new change from surgeon leadership. So for the medications, it's sequence 1035. It's the beta blocker more than 2 weeks. It's the calcium channel blocker more than 2 weeks. It's the long-acting nitrate more than 2 weeks, and it's the other anti-anginal more than 2 weeks. So if the patient is on one of these types of medications at home, okay, so not the STEMI patient that just comes to the hospital and gets put on a beta blocker. We're talking about patients that are on home beta blockers, home calcium channel blockers, home anti-anginals, home long-acting nitrates. Then you can code yes to the 2 weeks questions because they're on them at home. You don't have to go look for proof that they were on them for 2 weeks at home, okay? But for this particular patient, this patient came into the hospital and put on a beta blocker. So that patient doesn't qualify for this home beta blocker because they weren't on one at home. So yes, Alana, you would answer no to this patient because he was only on it 10 days and he was not on it at home. Does that make sense?
It makes sense to me.
Okay.
Okay, and I just deleted another question just because it was the same. It kind of was asking for clarification on the same. How do we enter a prior history of TVAR zone 2 through 5 in the M2 prior aortic intervention sequence 4510?
Well, what I would do, Ramel, is we code yes to prior aortic intervention sequence 4510. And then since we were covering, we got zones 2 through 5. I would choose arch zones 1, 2, and 3, and then descending zones 4 and 5, because they actually had a procedure in multiple zones, and there's a choice for each one of that. If we had the training, if we had the data
Yeah, let me-
collection form pulled up,
Yeah, let me pull it up. Hold on one second.
I'm looking at it because I've got it pulled up. but
Yeah, you were
if
going through it and I was picturing it in my mind and I'm like, yeah, that sounds right. But I'm like, oh, probably be nice to share. So hold on.
I can see it because I've got it pulled up.
I'll pull it up here. Sorry, everybody. What's the sequence?
4510. So this patient had a T-bar. I lost my questions now. Let me pull them back up.
Zone 2 through zone 5.
Yeah, zones 2 through 5. So you'd say you would check the arch zones 1, 2, 3, yes, prior there, and also the descending zones 4 and 5 to capture all the zones of the prior intervention.
Right, because it sends in all of them. I
Yep.
think, right? Yeah. Okay. Thanks, Melinda. Great question. If documentation clearly shows that a beta blocker was started 2 days prior to an elective admission for cabbage, do we still say yes to 2 weeks for beta blocker? I think
Yes, the patient was on a home beta blocker. The real intent, the physicians they're trying to align with NCDR a little bit, okay? And they're looking at care of that patient prior to coming in. Was the patient on appropriate medications? A beta blocker, calcium channels, anti-anginals, things to improve the patient's cardiac performance prior to surgery. So yes, the answer would be yes. Home, they were on a home beta blocker.
Thank you. Okay. Audit questions. If we were included in the sites that were audited, would we be notified? Yes. If you're going to be audited, we inform. Emily, are you on? I believe we perform.
The primary data and file contact and the surgeon representative. And if we haven't plugged this, please make sure that your contacts are up to date so that we're getting that notification to the correct people.
Great. Thank you. And then how do we know if our site was included in the audit?
The sites from last year, they received their audit results, and those were also sent to the primary data and file contact and the surgeon representative.
Thank you. And how do we know that we have 100% from the audit? I think only we know at STS. If we went away from providing grades or percentages back to sites, but go ahead, Emily.
Yeah, it would have been in a table overall. Would have been in a table. So they would have received that.
Oh, thank you. It's in one of the Excel sheets, Excel pages.
Yeah, so in the summary report that you receive, there's a table that shows a summary of audit results. So for each form section, and then the overall agreement rate. And then we also provide the overall grade. So you would have received all that information there.
Thank you, Emily. Please let me know what is the total number of variables for the audit. So for this last audit, it was 132.9 data elements. For the next audit, it's going to be around 125 because of the version change and going from uniselect to multi-select. So we're auditing just about the same variables, but the number is just going to be a little bit different. Hi, Heidi, and your pneumonia, post-op pneumonia request. And I think you actually requested it prior to August 2021, and we've been working on it for quite some time. I really hope that it is added in the very near future. We're working with IQVIA for the enhancements. And this is, we're going to have a couple different pushes of updates come out from IQVIA. This will be on the first one that comes through. So please, it is on our radar, and we are tracking it. And I hope that it's updated very soon. I don't have any dates yet. of the sites who didn't do well on the audit, were they using a data abstraction company? And I don't know that I don't know that I have that information. I know that we asked that, but it wasn't provided back to me that way, so I'm not able to share it because I don't have it. But it's an interesting question. My facility does not have an aquafreeze machine. If we're to use our Prismaflex on a CUF mode, slow continuous ultrafiltration to remove fluid, would that count against us as dialysis? Melinda, I
Well-
believe this has to do with if they're using diacylate or not, correct?
Yeah, and if they're just removing fluid and they're just doing ultrafiltration, then that's not captured as dialysis.
Great, thank you. And it's in the training manual.
It is.
Are audits done purely on medical records? I am wondering how follow-up documentation that proves no 30-day mortality in any readmission outside of our facilities are caught. So we do it on medical records, but it's also, we also ask sites to provide any supporting documentation. So this would be captured on your logs that you keep for the 30-day and readmission follow-ups. We're really just interested in, we're primarily interested in if you have a process in place to track your patients, because we obviously can't call all of the facilities where you may have transferred patients to, or that not transferred patients to, but could have been possibly readmitted within a 100-mile radius or something crazy like that. There's no way for us to really to do that. So we depend on your tracking documentation, and we ask for that to be provided as part of the audit. If a site does not meet expectations due to data not being sent in for review, is the site given an opportunity to provide missing data? We did work with a few sites who had some lapse in the data that they sent us, and were able to update their results because they had missed sending that to us. We're going to make that more of a formal process with the audit company, in that they're reviewing the data they're receiving. If they are missing data, to reach out to the site to work with them ahead of time before the audit is performed. And then in the result adjudication process, that will be something else that they are take into consideration.
Carol,
And
can I just add a comment? We did not allow, I'm going to add a clarification. We did not allow sites to send information that was not sent initially.
Thank
If
you.
a site had information that they sent to our auditors and they could provide that they had sent it, it was there, it was correct, whatnot, we looked at that, but we didn't allow for, to send more information this year. But that'll be corrected in 2023 or for 2022. Thanks.
Thanks for the clarification, Emily. And Annette then says that her facility has a vendor that pulls their audited data, not our medical records. The abstractors try to check it for completeness, but sometimes due to workload and timelines, this isn't always possible. Yeah. So I'm just asking if you could please, have something in place that if you do have a third party pulling your audited information that's to be sent to us, to please just try to set some time aside just to review it. Because I hate to see sites get marked wrong for things that they're actually doing, but they're just not providing in the audit. Vanessa is asking, can we provide more about the audit process, like a quick overview of what happens, what they look for? So they have our list of variables. They pull the data from the warehouse. They compare it against what's in the medical records or the documentation that you send them. And they use the training manual that's appropriate for that, the date of the case that's being audited, whatever updates are in the training manual for that time. And then if there's a mismatch, they would mark it as a mismatch, and that's how you would get your, that's how you would find out how well you're performing. I hope that helped, Vanessa. No problem, Heidi. And Julia, can you please repeat when it is foreseen that the H1 reports will be posted? I'm not sure when they will be posted. I'm hopefully sometime in early May, but I don't have a date yet. We're still waiting for the data to come back from DCRI. Is insurance coding required? It is not. Insurance is, I have to check on that, Julie. I'm not sure if that's a PHI field or not.
Well, it is in the risk model if they're on Medicaid or Medicare or whatever.
Yeah, that's required. I just wasn't sure about like the HIC number.
No, I don't think that's required, but they need to put the primary and secondary payers in because that's in the risk model.
Mhm. Can you please send out the results you're discussing about the audit? So I can't send out these results. I have the slides here for you if they'll be posted, and you could pull them down if you'd like. If our source document says weight height used is from anesthesia record, is that acceptable?
Yeah, that's actually the priority source of the training manual. So followed by the perfusion record. I've been reading, there's a lot of comments about this throughout this whole train. So the training manual instructions are to use the anesthesia document first, followed by the perfusion record. And then if neither of those places have any documentation of height or weight, then you can go to another source that is closest to the time of OR entry. So if there were height and weight discrepancies in the audit, it was probably, my guess is probably because they were not using the sources as identified in the training manual. That would be my best guess.
Yeah, I think you're probably right, Melinda, and that's what the auditors are looking at, the anesthesia record as the priority source. So if you're not using it, it's going to be a mismatch likely. And you have it right here in both of them. So hopefully that's helpful. Okay, thanks for the comment, Hannah. And then Judy, yep, it's the anesthesia record. What is an example of a tracking document? Do you have any examples of that? To me, Melinda, that's just an Excel spreadsheet where you keep a list of your patients that had surgery, their OR dates, their discharge dates, and when you did your 30-day follow-up on them and checking for readmission within the 30 days post-discharge.
Yeah, it could be an Excel spreadsheet. It could be a Word document. However, whatever's easiest for you to track. You know, I checked the readmit here. I checked mortality. You know, it's just I think most people probably just use an Excel spreadsheet.
Yeah, and it doesn't have to be fancy. It can just be patient, the date of surgery, the date of discharge, the date that you're going to check the 30 days on, which is nice. If you enter that date in, you can just sort on that when you're doing your follow-ups on your patients, and just check all of those that fall within that, you know, the time frame that you're checking. Then the 30-day post-discharge date, which is the just put another date in, 30 days post-discharge, filter on that and check the patients, and then just have a column for comments that you comment on both the mortality status at 30 days and the readmission status post 30 days discharge. Yeah.
Yeah, it can be pretty simple.
Yeah, it doesn't need to be fancy. And then new FAQ addresses renal fail, risk factor, inhaled medication or oral bronchodilator therapy. Definition still states medications were in use by the patient routinely prior to this procedure. The new FAQ states this can include PRN inhalers now. This opens up a lot of questions for us. If there's a PRN inhaler prescribed but hasn't been used for months, do we include this? This would mean that we'd have to code mild lung disease for asthma patients whose PFTs do not meet the mild lung parameters outlined by the training manual.
Okay, so Carol, maybe you can pull up 455, the sequence. So
in the training manual?
Yes, thank you. So to address this, so we updated this in the training manual. And first of all, we cannot change definitions. So when I have to clarify things in the training manual, I cannot go in and change the definition, because that can only be done when you are upgrading the version. Okay, so any changes, any clarifications, any instructions and coding that we need to relay to you guys has to be given either in the intent clarification or FAQ. We cannot change the definition. So that's why the definition still says routinely prior to this procedure. But if you'll look at the training manual for the update, you will see that under the intent clarification, where we can update things, it said the word routine is marked out. So it says this can include regularly scheduled and PRN inhalers. This was surgeon leadership, felt like they wanted to capture patients on who use inhalers at home. And as the surgeon said to me, most patients use them when they need them, and that is PRN. So that hence the change. To address the other question about chronic lung disease, then yes, this patient would have an inhaler at home, and that would qualify for mild lung disease.
Thank you, Melinda. And then there's questions here. I'm not inadvertent or just ignoring these. I see the questions regarding tracking and things like that. I think we answered it about using Excel spreadsheets. So I'm not going to reread them. The question about adjudication on audits, the audit company will be doing adjudication on results on this next audit go around. And the other question is, how is the auditor accuracy verified? I review the results along with the adult task force chair to make sure the audit company is in line. It's an okay process for right now, but it's not as good as having the results adjudicated. So that is going to be implemented in this year's audit. Yes, the anesthesia record closest to the anesthesia log is accurate to collect the height and weight. If the 30-day status readmission is already documented in the EHR, do we still have to collect the information in the tracking sheet? You do not, but just make sure you include that information, and it's done for all of your patients. Make sure that you include that information when you send in your, if you are audited, that you send it in with your audited documentation or your documentation that's to be used for audit. What I saw is that there were, I would just be careful with that process to ensure that all of your patients have the 30-day in readmission status in the EHR. Because I saw a few sites where they had most of their patients, but there were a couple patients who were not documented in the EHR for those two fields, and they caused them to have a mismatch because they didn't have another process in place for tracking those other patients. So just be aware of that. Hannah made a great suggestion in auditing the data yourself prior to submitting and looking for missing data prior to submission. That's a great suggestion, Hannah. Thank you. I would just also caution that we'll provide the audited variables up on the website. Pretty much we focus on risk model variables and the labs and the post-op complication section for the endpoints, including readmission 30-day. Just make sure, remember that you cannot, once the data is in the warehouse and we pull it for audit, anything that you update after that time frame will not be included in the audited data. So just be aware of that as well. The change to tell participants to go back to previous echoes to fill in missing values from the most recent has muddled things with auditing inter-rater reliability and adds to abstraction time. Melinda, are you clear what Karen's comments is?
Not exactly. I don't know that there's been any. There's language in the training manual that talks about if the echo closest to surgery doesn't have a particular value on it, but then you have another one that was done, say 2 weeks before that one, then you could use the missing information off the one that was done 2 weeks prior to the closest one. So that's the only thing I could think that maybe she's talking about.
Yeah.
Sure.
Feel free to add some clarification, Karen. I'm not sure. I appreciate the comment. I'm not sure that we're catching it. Sorry. we are a new program. When can we expect our first audit? So we don't, you could be audited at any time. If you are audited, you're passed over for the next 3 audits. Is that correct, Emily?
Yes.
Okay.
It's a random selection.
Thank you. Would a patient using albuterol PRN for asthma with normal PFTs or PFTs not done be considered to have lung disease? And I think you just answered that, Melinda.
Yes, yes.
Mild. Okay. When will the audit happen? The audit is going to happen again in 2022 and we'll notify sites May, June time. No, so the next audit, it will be approximately 110 sites. The 10 sites that need to be re-audited will occur in 2023. So they have a year to kind of clean up their data, get, if they're having issues, kind of get resituated and reach out if they need help with things. So we wanted to give them a little bit of time to recover from an audit and get caught back up if they needed additional assistance. And then they will be re-audited in 2023, and they will count as part of the 10% that we audit. The audit variable list is located on, if you go to the sts.org and then STS National Database, this is the homepage of the database. If you scroll down just a little bit, you'll see a tab here that says audits. If you click on that, this is where you'll find the audit policy. And then you'll also find, this is the instruction letter. And I believe this has the list. I hope I'm in the right spot. It has the list of the variables here. This is 2.9. It has not been updated yet for this next audit. It will be updated soon.
So Carol also put a link to this page in the chat box for anybody that needs it.
Thank you.
Mhm.
And it's 3:01, Melinda. Do you have extra time to stay on and maybe we can get through some more of these questions? There's quite a few.
Yes, because if I'm not doing this, I'll just be answering questions in the mailbox.
All right.
Might as well answer them here.
Hop off. Feel free. We're just going to try to answer as much. So if you're still on and you've asked a question, just hang out for a little bit. We'll hopefully get to it. When a patient is re-intubated more than once, how is that captured?
Well,
go ahead.
I'm absorbing the question. So I'm assuming this patient was extubated and then got re-intubated one time and then got extubated and then got re-intubated again. So what you would do is
Hey, beautiful, you've got a text.
oh, sorry, that's
Melinda.
my text. Sorry,
Yeah, that's
guys.
Melinda.
I love that. That's fantastic.
Let me turn that off. Yeah, that's the only time somebody calls me beautiful during the day is when my text goes off. So anyway, so let's go down here to re-intubation.
I think it's up here, right?
Yeah. Okay. So we would here it is, re-intubated or intubated post-op. So you say yes, they were re-intubated. Now, to get the hours, you're going to have to add. Let's say the patient was re-intubated twice. So you'll have to calculate the first re-intubation, how many hours that was, and then the second re-intubation, how many hours that was, and you would put that in sequence 6595, the total of the re-intubated. If they were re-intubated 3 times, you do the same thing.
Thank you. Thank you, Melinda. Pulling weight from the anesthesia record is the right thing to do, Amy. Thank you. If my site is chosen for the audit, how long would we have to complete the audit? Emily, do you want to talk on that? I don't want to give the.
Oh, how long it'll take to complete the audit? Gosh, I'm not quite certain. I know that we give about, I think it's 4 to 6 weeks to complete the audit. Carol, am I misspeaking by saying, I mean, it takes some effort.
No, you're not misspeaking. I agree with the
Yeah.
4 to 6 weeks. If you are chosen for audit, the audit company will reach out to you. They'll let you know, we'll let you know you're chosen for audit. The audit company will reach out to you usually within a couple of weeks of us contacting you and notifying you.
Correct.
And then they'll give you a timeline of, they'll let you know what needs to be submitted. They even provide a pre-audit call, if I'm not mistaken, Emily.
Yeah,
with the site.
if you have questions. Yep.
Yeah, with you to help you prepare what needs to be pulled and sent in and how to send that in. And then once you send that information in, it could take a couple months for them to audit, depending on where you fall in the process.
Mhm.
So some sites were audited and they didn't get their results back until January. So just, be aware, and if you have questions and you're wondering where your results are, you can always reach out. If you haven't been, if you're questioning that, to prepare for the audit at your own site, I have heard that it can take up to 40 hours to prepare your data. So that's why we don't, if you are audited, we skip over you for 3 years because it's quite a bit. So I hope that answers your question, Dana. I also agree with anesthesia record not being accurate. I look at the pre-op holding RN documentation as they actually weigh and measure height just before surgery. I think that should be considered.
Well, I think that we decided in the training manual that the anesthesia record's the priority source. So, and then followed by the perfusion. Then if there's no documentation there on those two priority sources, then we go someplace else.
Mhm.
Because the care of that patient from that anesthesia provider who is managing the medications and stuff while the patient's during surgery is being based off of that weight that they're using, that height and weight.
Yeah, that's right. I agree with you, Melinda. Our surgeons want us to use perfusion. Okay. So Karen has worked with the anesthesia to communicate with the perfusion and use the same source and value. So that's great, Karen. Good job on the team communication. If we submit a patient's data and we do not have a signature A form on file with STS, will that provider's data be included in reports? Right now, we do not have a check in place to do that. We are working on the communication between our internal database of sites and providers to communicate with IQVIAs. So it will be checked. It just is not in place at this time. And those files, if they're not on signature A, they will be rejected in the future. So they are only auditing CABG, aortic valve, and CABG aortic valve cases. That's correct. That's because we have to limit it to a smaller population so that we can come up with results, because we only audit 20 cases at a site. So we want to have specific populations that we're auditing. In the future, it is likely that we will add on aorta cases. So, and it also keeps it easy for data pull when we're pulling the data to focus on these specific cases. So, to clarify, patient comes in having been on a beta blocker for 1 week because I have clinical record and know it when it started. So now, since they were on it at home, I would mark yes.
Yes, that's correct. As of the April 1st, 2022 update. If they're on a home beta blocker or calcium channel or anti-anginal or other anti-anginal such as Renexa, and they're on it at home, code yes to the 2
And
week
this
question.
starts, I see a question further down in the chat box or in the question box. This starts with April 1st cases, OR dates of
Yes.
April 1.
Yes, that's when the update came out.
Okay, thank you. Can you show us again how to get to a question number quickly? So
I think she's talking about the control F.
oh yeah, okay, so for this is the training manual. So I either go to edit and do find. On a Mac, it's this funny thing here in F. On a PC, it's control F, or you can just click find. But if you do the control F or that funny thing F, this box will pop up and you can just type in the word and it will come up however many times, and I spelled fraction wrong, but it'll pop up there for you, or you can type in the sequence number or short name. I like the short name because it's going to be the same thing on here. So if I wanted to see the definition with any intent clarifications, I could just copy and paste this right from the DCF online, go into the training manual, do the control F and paste it, and then that field will pop up There's just some tips and tricks.
And there's also the bookmarks. Just show
Oh,
them
yeah.
while we're there.
Bookmarks is the hamburger. I'm hungry is the hamburger. And then if it pops up like this, it's going to be the second tab. And I know that's very small, but here's risk factors. And then if there's an update underneath that specific section, it will be late. It will be bookmarked with the update for the month. So, okay. What if the patient was in the hospital 2 weeks prior to surgery and was on beta blocker during that time, but not prior to admission?
Well, if they were in the hospital for 2 weeks, then yes, you're going to answer yes. If they weren't on it at home. Okay, the change really has to do with home medications. Were these people on these medications at home? If you have a patient that was not on it at home, but they are in the hospital 2 or 3 weeks before they have surgery and they get put on one of these medications, then you can still code yes for that because they met the time frame.
Okay.
Despite not being on it at home.
Okay, thank you. And I think we just answered the question that this started with April 1 cases.
Yep.
Okay.
Um,
The September 2020 update for 6595 says not to round vent hours, but the example beneath shows rounded numbers. Oh, brother.
Well, it does, but it doesn't. Pull that up. If you look at the specs for sequence 6959,
Oh, yeah, let's pull that up. Hold on.
we have 2 decimal points after, after the number. So it's 2 decimal points after. So in the example, Peter, the vent hours were 50.626. And I said to enter them just as 50.62 because the specs allow us to enter to the hundredths point in that particular field.
Some vendors allow, they don't have any cutoff for the number of decimal points that you can enter, or values after the decimal point that you can enter. The specs are listed out to the second to the hundredths. So that's what's expected. And what the training, like Melinda said, what the training manual is saying is that since it's only expected out to the hundreds, just to cut it off, truncate it at the hundredth spot, right?
Yeah, and not round up. So like if your vent hours come out as 50.626, all you need to enter into the tool is 50.62. I don't want people rounding up to 50.63. I mean, if your vendor lets you enter 50.626, enter it because you're not rounding it up. But if your vendor only lets you enter 50.62, only 2 points after 2 spaces after the decimal, don't round up if your actual number is 50.626. You see what I'm saying?
Yeah, just truncate it. Leave
Yeah.
the 6 off.
Yeah.
Okay. Does the auditor debrief the site of their audit results? Are we doing did we do post-audit calls this time, Emily, or?
We did not this past audit for adult cardiac, but there will be an opportunity to talk with our auditors this year, 2022.
Thank you. And I think the reason is this is our first year with the audit company HMS, so we're both learning from one another. So it's just kind of a learning process with what the sites need and how best HMS can help serve those needs. So please clarify the question that was just discussed about home beta blockers. If the beta blocker was started, okay. If the beta blocker was started 2 days prior to surgery, do we code yes?
If it's at home beta blocker, yes, because the physician prior to admission was appropriately treating this patient with a beta blocker. So if it's a home beta blocker, remember we can't change the definition. We can only change the intent or the clarification with updates.
Okay, how about we take all the beta blocker questions and we discuss them on the user group call that's coming up?
Yeah, we might
Because
have
I think
to.
we need to, okay. If there are no echo results in the record, neither pre-op or intra-op, how should we answer the hemodynamics portion?
If there, okay, so no echo at all. So just say no. That's how you do it. If you go through, Carol, pull up the data collection form. Go through, I think that starts somewhere around 1540, something, somewhere around there.
Down here.
Oh, you're scrolling. Okay, so down a little bit further. There, so ejection fraction, say no. Dimensions, no. PA, no. Aortic valve regurg, no. Aortic stenosis, no. Just say no. Answer no. There's directions in the training manual about that. If you don't have any information at all, just code no.
Thank you. Okay, and then if the patient had pneumonia as an inpatient prior to incision, and it is mentioned in the postoperative note, is this captured as both pre and post-op?
Well, it depends. I mean, was the pre-op pneumonia cured prior to surgery? And this was a new event post-op? It depends on the situation. And because sometimes, you know, you can treat it pre-op and the patient doesn't have pneumonia going into surgery, but then post-op, maybe the patient was in the hospital 30 days and got another bout of pneumonia. So it really depends on the situation.
Okay. My concern for removing post-op high creatinine from the audit is this: if it is 90% of the time of those sites are not clear. It wasn't that they weren't clearly documented. It had to do with rounding issues when we looked at the data. But yeah, I understand it. I'm going to look into that a little bit further, Michelle. But when I reviewed the data from the audit company, it was because sites were rounding the data or just providing whole numbers when we expected the results out to the tenths. So I appreciate that. Thank you. Do we have to submit proof from the EHR or EMR of lack of mortality or remission, or is a spreadsheet that we keep enough? The spreadsheet is enough. We're just mostly interested in the tracking documentation. But they do ask, I believe, for your discharge notes and your post-op notes. So is coding the intraoperative TEE pre-incision data accepted?
Yeah, go to the priority source document in the training manual. There should be a bookmark for that. Capturing of hemodynamic results down the source document. All right, so
It went
here,
I was clicking and I was already there. Sorry.
so here it is. So this is your source document. So number one is the pre-op results captured from objective studies. Closest and prior to OR entry within 6 months. However, we can go up to a year if we need to. The second one is to use the OR pre-incision results if the pre-incision results change the planned surgery. Okay, so if you get in there and pre-op you had mild mitral valve regurgitation, and you get in there and all of a sudden the surgeon notices severe and he's going to do an MV repair, then we're going to code severe for the mitral valve regurgitation. The third priority is use the OR pre-incision results if no other values are available. So in Julia's question, she didn't have a pre-op echo. So yes, you can use those pre-incision ones if you have no other echoes available, or if the valves were not visualized in any of the pre-op exams, regardless if the planned surgery was changed or not. And then the fourth priority is if you've got no other results available, no objective studies, then you can use surgeon documentation. We did this in an effort to make it easier for the data managers to identify which documents they should be using, encoding the hemodynamics. And I think maybe it helped because the audit results were quite a bit higher than normal. And we changed this in version 2.91. I don't remember exactly when, but I'm hoping it's helping.
Yeah, it's helping. And I wanted to show, this is the training manual. Melinda has bookmarked this information about the log. So it's under, it's towards the bottom here, right here where it says 30. I know you all can't see that. It's pretty small, but it says 30-day mortality, 30-day readmission, 30-day deep sternal wound infection log. So if you click that, it's going to give you information where it says data managers need to keep some type of log to include verification source, data set, and status of mortality, readmit, DSWI. So there is information here, and there's an example of what can be in that log. So hopefully that's helpful. What do you suggest one does when we're approaching the pre-op 2-week beta blocker to the day rather than the perspective of whether they were just prescribed PTA, even if just on 2 days PTA, as in prior question?
Well, we did this to make it easier for you guys because I get questions, many questions all the time. The patient's on a home beta blocker, but I don't know how long he's been on it. And I can't find any documentation how long they've been on it. And so in an effort to make it easier for you guys to fill out these 2-week questions, the surgeons felt like, well, if they're on at home, let's capture it because the patients are being managed appropriately and they are on at home. And so that's why we changed it, to try to make it easier in the long run. So as you're going through your medical records, and some people have medical records that I think are challenging. Actually, a lot of people do because I get a lot of questions about this. And if they see the patient's on a home beta blocker at home, they can just go ahead and code the 2-week question as yes.
Thanks. Thank you, Melinda. Okay. If patient had endocarditis in 2018 and now comes for valve surgery in 2021 and does not have endocarditis pre-op, how do I code?
Well, it would be, yes, a history of endocarditis. I think that's sequence 385.
Yeah.
So yes, they've had endocarditis because the time frame is from birth to OR entry. And then the type would be treated because it's not active. They don't have active endocarditis right now.
And then I saw a comment from Peter Fleming that says the event hours were rounded. It was beneath the 2020 September update.
Yeah, and I look at that and I can't figure it out, Peter. Will you send me that in FAQ, exactly what you're looking at? Because
What do you know what field that is, Melinda?
yeah, it's 6595, I think. And I don't know. Maybe 95. I see there's the example. You just passed it.
Yeah, it was just clarification. I don't think anything was changing in this.
So I don't know. Peter, just send it to me if there's something I'm missing. My old eyes are missing.
When audited, do they use the STS training manual or can the site send their specific guide of where to get the individual data points? So they, the audit company will use the training manual and they'll pay attention when updates were entered in. So, and that's not really a good one because it's just clarification.
Well, I think what she's getting at here is the priority source. So not everything in the training manual has a priority source document. Only certain things do.
Yeah.
That.
Yeah, what I was going to add, I agree. What I was going to add to that, Melinda, is that the audit company will ask you to bookmark your documentation so they know where to look when you send it in.
Yeah, but I think a thing like weight though, since it's in the training manual, it says this is what you're supposed to use first. That's what the audit company is going to use.
Oh yeah, that's right.
You know, because we have identified a priority source. Not everything in the training manual has a priority source because you just can't identify all the priority sources, but certain pieces of information, like I just updated, in April, I updated like for a bypass time, I updated and said the perfusion record is your priority source for this, because I kept getting questions. Well, my surgeon says this minutes, and anesthesia says it's this minutes, and perfusion says it's this minutes. So what is it? So we have to, we had to make a decision which should be the priority document in this particular situation. So certain things in the training manual will have a priority document, and that's what the audit company will be using off of.
Thank you, Melinda. I only have about 5 minutes left. So we're gonna have to, I think Julia is correct in using the perfusion if it's not documented in anesthesia. 30-day follow-up readmission information is documented in the EHR. And yeah, that will suffice, Beth. Just make sure that it's included in your information sent to the audit company. They're looking for anything that the site uses to track. And that's fine. And then on any outside readmission or mortality event, we enter this information on our STS software tool. If we extract these information from the STS software, will this meet expectations of a tracking document? I don't see why not. Let me discuss this with Donna and the audit company and make sure that we're on the same page with this before I provide an answer to that, Ramel. Do we count one-time doses of pre-op ACE or ARB as yes for ACE ARB within 48 hours?
I don't know. Let's see what it says in the training manual. I look at the training manual all the time. Let's go to, yeah. I think it says, I don't think it's specified, but I don't want to know for sure. Yeah, it's not specified. So they want that. Yeah, so they want a one-time dose, it looks like. There's no indication that we're not. And I thought that was the answer, but I wanted to make sure. So yes, capture that as an ACE ARB, because ACE and ARBs do affect kidney perfusion prior to surgery.
Yeah. We are also allowed to submit a zip file of FAQs that we have asked and saved as well to submit in an audit, correct? I believe that they will use that, but it shouldn't be anything that's not in the training manual, hopefully.
Well, there may be a few that
Okay.
sometimes I tell people, save this in the event of an audit. It's a very unusual situation or particular way to code it or something, or
for those, if it's a one-off type of case and it's a unusual, like Melinda said, unusual, then
or the IMA acceptable, other acceptable reasons.
Yeah, that would make sense then. Yep, I would agree with that, Bonnie. Procedure coding question: should a PFO closure of a PFO be included in the database as other?
Well, we have the PFO under other cardiac right there. PFO 4138. There's a PFO repair right here under other cardiac. So you would do other cardiac procedure and then come down here and code sequence 4138 for the PFO repair.
Thank you, Melinda. Could the date the cases are pulled from the warehouse for audit be posted for those facilities involved? We'll have to work. It kind of takes a little bit of a coordination between us, the warehouse, and the audit company. If we're not able to do it this year, we'll do it for next year. But I did ask Emily to make sure that we have it on the list of things that we would like done. If there is no pre-op procedure echo or missing elements, can we use the initial OR echo? And I think you just answered that, Melinda.
Yeah, the pre-incision TE, in the OR. If you got no other results, yes, you can use it.
Yeah, it seems the Cerner EMR definition of race and ethnicity doesn't match that of STS. How to deal with that? Will you please email me that with some screenshots of what you're saying? Because the STS has specific definitions that I believe align with what we use in CMS. It came from CMS. So I'd like to look at that a little bit closely. If you could send it over to me in an email, please. The intent of the 2-week beta blocker and meds is in alignment with guidelines for maximal medical therapy treatment for coronary artery disease and heart failure, etc. The longevity of treatment impacts survival and outcomes. I understand wanting to capture home prior treatment, but regardless of home prior and hospital days versus weeks matter. Could you ask surgeon leadership to reconsider the intent of the guidelines and the original duration of greater than 2 weeks of therapy?
We can look into that, but that, like I said, we've aligned with the NCDR in their interpretation of it.
Yeah, and I'm not sure. Yeah, and maybe we could provide more information about this and how we're not. It is for maximal medical treatment of coronary artery disease and heart failure, but I think the reasons we're giving beta blockers specifically for the CABG patients is the post-operative atrial fibrillation aspect. So maybe we could provide more information about how it's specific to this population and why we're not so concerned about the 2 weeks.
Right. We're not as concerned about the 2 weeks. The main one we're concerned about is that pre-op beta blocker within 24 hours
Yeah.
and the beta blocker therapy after surgery. So
If you're chosen for audit, how long do you have to get your data together for submission? It's usually, I think, six weeks or so. So the audit company will give you that information if you're chosen. As we are often abstracting cases post-surgery. Oh, I gotta go. Let me see. Okay, this will be the last one. I apologize, everybody. If we didn't get to your questions, we have a user group call in a couple weeks, and we'll be on that together. So please save your questions if we don't get to them. And this will be the last one from Sarah. As we are often abstracting cases post-surgery, such as those from the month previous, would we not make the FAQ changes until the surgery that corresponds to the month? For example, I am abstracting March surgeries, and would I simply keep the beta blocker rule as 2 weeks, even though I have read the April FAQ? Ignore the change until she starts April surgical cases.
yes, that's what you're supposed to do, because that's what an auditor will do when they're auditing your record.
Yes, that's right. Okay. And okay, I apologize, everybody, but I have to go for another meeting. I thank you, Melinda, and thank you, Leanne, for staying on with me. Thank you, Michelle, and thanks everybody for joining. I'm sorry that we couldn't get to all the questions, but we'll have our user group call in a couple weeks and hope to see you all there. So thanks, everybody. Thanks again, Melinda.
Oh, Melinda, great
Thank
call.
you. All right, bye.
Bye, everybody. Thank you.
Bye.